Hello, everybody. Welcome to the Very Connected podcast. We have our October support group, and tonight we're being joined by Dr. LLOYD STEGEMANN. Say hello.
Hello, everybody. Welcome.
So gracious, and we're so glad you guys are here. We got a lot for you. Dr. Stegemann's been working on his presentation, and he was talking about having to pare it down because normally what he teaches in his prescription for success, his aftercare classes, is a lot. I mean, would you say 4 hours of material?
We're going to pare it down to 45 strong minutes. That's what we'll do. So
it's going to be awesome. It's going to be jam-packed. And I want to do like a brief introduction on him. And also I want you guys to do an introduction on yourselves. If you're joining us here live, please let us know where you're from, if you're pre-op, if you're post-op, if you've had bariatric surgery, any successes, because we want you to share amongst yourselves. This is all meant for people who are either thinking about having weight loss surgery, who are pre-op, who are post-op. So all of those, let us know. We usually have people from all over the United States, and it looks like Canada too as well. Sometimes we actually even have people that come in from, I don't know, internationally. And I'm always surprised because I'm like, that's exciting. So let us know. In the meantime, while you're all commenting, I'm going to go ahead and just kind of share a little bit about Dr. Stegemann here. So Dr. Stegemann completed his medical school training at University of Texas in Houston, and then entered general surgery residency training at the University of Texas in San Antonio. After completing his residency in 2003, he focused his practice on medical and surgical weight loss and maintains a busy practice. So that's a lot of years, over 1,000 patients and over 250 operations normally performed yearly. And he serves currently as a director of bariatric and metabolic surgery at Bay Area Hospital in Corpus Christi, Texas. I think this is so interesting. You've also been instrumental in organizing the practice of bariatric surgery in the state of Texas. And you first organized the first bariatric surgeons in the state, the first meeting in the state, which led to the creation of Texas Association for Bariatric Surgery, which is also abbreviated TABS, like TABS, and was elected by his peers to serve as the first president of TABS. And I know TABS has gotten to be a very large organization now. And I know that yearly they have different types of conferences and things. And also, you're also part of the FASMBS and has been sought out as a author speaker by his patients and by his own professional colleagues and patients. And we talked a little bit earlier about his prescription for success bariatric surgery long-term aftercare program, and he's going to be just kind of sharing some tips and different things from that. I know outside the clinical setting, you also enjoy time with your family, playing golf, traveling, and all kinds of other fun things. And from there, I feel like I'm probably not even doing you justice because I know after meeting you, you have such a broad knowledge of all of this. With being in the bariatric field so long, I know you probably have seen so many patients. And I think it's interesting because you probably hear what, like on almost a daily basis, what the struggles are, what the challenges are, but also what the successes are and how to kind of get around that. I didn't realize I was sharing my screen, so I apologize about that. I was trying to just give your bio. Was it sharing my agenda screen?
I saw a little bit. It's I like to know what to prepare for, so it's perfect.
So kind of give us more details about what you're doing. What got you in the field of bariatric surgery, first of all?
Yes, well, thank you very much for the kind introduction. I appreciate it. I loved internal medicine when I was going through medical school, family practice, internal medicine. I really, really enjoyed it. And what I enjoyed most about it was the relationship that those physicians had with their patients. And, they would, get to see them for years. And then they saw the kids of the parents. And it was this generational type of thing I thought was really neat. But I got to tell you, once I did surgery, that was it, man. It was so cool. You could go in, you could fix something. Was great. And it was my intern year in general surgery that I first got introduced to bariatric surgery. Was the first time I actually saw it. And immediately I knew that's what I wanted to do. Because it brought together both of those worlds of internal medicine, where you get to take care of a patient long term, plus the really cool part of surgery. So I was hooked. Literally, I think I was my second month of general surgery residency that I knew I wanted to do it. And so I actually was lucky that I went to a residency program that did lots of bariatric surgery. They were really one of the leading places. And so I took so many extra rotations because there's a lot of surgeons that don't like it. And so it was easy to get those extra rotations. So I came out with a lot more experience than most people would have when they, finish their general surgery residency. And I still love it as much today. It's I can't imagine doing anything else, quite honestly. I love it. Love it.
What's your favorite part, do you think, of being in this field? What do you enjoy the most?
So I would say it's a couple things. Certainly the thing I love the most about it is there's so much we don't know. It's still a field that really is growing, and our understanding of obesity and our understanding of the physiology behind it is fascinating. There's every year we're learning more and more, and still trying to get to a lot of the root causes of what's happening and why do these surgeries work? What is it about it that makes these work? And why don't they work for everybody? When you look at the graphs and you do a gastric bypass on 1,000 people, you're going to see, a weight curve that's, up. Some people do great. Some people don't do quite as great. Why is that? And I think we're still coming to those understandings and understanding the genetic component of obesity and where do we intervene there. I think that part is really fascinating for me, that there's still lots of room to grow within the field. And then, the surgeries are cool. And so it's technically challenging. So it makes your brain work there. And then in the clinic, I mean, I just finished seeing patients, and it's still a joy. I mean, you see patients who, someone just walked out of my office, has lost 100 pounds, talked about, how great life is now because she can play, she's chasing her grandkids. She's, those simple things that, people that don't struggle with their weight, just don't get, don't understand. It's cool. It's cool. And, why do we go into, well, I guess, why do doctors go into medicine? Because we want to help people. And I look at, my friends who, ultimately went into family practice or internal medicine, and they're putting people on medicines. Oh, you got to take this now. You got to take this now. We're just the opposite. We take people off. It really is the making people better. Why you go into medicine.
I completely agree with you. I remember from my background, I did emergency room medicine, and it was so reactive. Like, I mean, of course, we all need the family practitioners, like you said. We need help sometimes in crises and emergencies and things like that. But what I love the most about bariatric surgery is that people typically generally want to be there. It's a choice that you're making, and they're wanting to transform their life in some way. So like you said, you're making so many improvements, whereas like a lot of times in the healthcare field, you're kind of just like you said, kind of fixing that or fixing this, and you don't always see the long-term results.
Yep.
You,
It's a great field. It's still a great field. And we make huge differences in people's lives. And it's that's the thrilling part to me, to see people really, who've always been there, is just kind of held back by the weight. And once you release those shackles, just let them live the life that they've always wanted to live.
Is it easy? This is one question I always was curious about. It for you now being in the field for so long. When somebody walks into your office and says, I want to have bariatric surgery, and you get it to talking with them, they're getting close to surgery. Do you ever have a feeling about the success level? I mean, you're going to be talking about some things that really seem to stand out.
Yeah, I've learned that I have no predictive ability when when it comes, because I think the thing that we don't understand, or people don't get. I get to ask this all the time. So if they do great with their bariatric surgery, why couldn't they do it without bariatric surgery, right? Because we have a very robust medical weight loss program too, and we have to do the same things with both of those groups of patients. But one group we use medicines, one group we use surgery. Um, the difference, though, is that our surgical patients get this enormous metabolic boost through the surgery. They get a number of neurochemical hormonal changes that the medical patient doesn't get. And this is what I didn't understand early on when I started. I don't think most of us understood when we started this, is that someone, once they've had surgery, a lot of times everything clicks now. That food noise goes away, and now the things start working. And almost every patient I've ever operated on, they know how to lose weight. I mean, they can lose weight. It's the keeping it off part. That's the hard part, right? And that's where surgery really helps, because of the changes that occur and it resetting the set point. All those things that they did before now are effective long term, right? And that's what really got me interested in this prescription for success, though, was not so much the person. I wasn't worried about them losing weight. I was worried about, are you going to see some weight recurrence, and what can we do to prevent the weight recurrence? And that started the observation of, well, what are some patients doing that other patients don't seem to be doing that makes a difference?
Well, I know you have a lot to share regarding this topic. So I say we just get started and just start sharing away. And I just want to say too that I'm so grateful for all of these wonderful people who've commented about their stories and where they're at and what's going on. So we'll continue to watch this chat. Feel free to chat amongst yourselves as Dr. Stegemann is talking. And there is a button that is a Q&A button. If you have questions that you'd like to ask Dr. Stegemann, please feel free to type them in there if you can. And the only reason I say that is because the chat gets so full sometimes. It's sometimes really hard for me. Like there was just 50 comments. And so it's hard to keep up with those sometimes. And the Q&A button's a good way to filter out questions. So please make sure you can put them in the chat box. It just might be just keeping an eye. I'll try to keep an eye on that too, but feel free to use the Q&A. But
Great.
go right ahead.
If I answer something as we go, just holler at me, and I'm happy to answer as we go. Otherwise, we can answer questions at the end, however you want to do it. All
That
right,
sounds good.
let's share this. And are we seeing that okay?
Yes, perfect.
All right, well, let's jump in there. So kind of the background of prescription for success and where it came from, it really came from two observations that I was having as I was seeing patients, that every single patient loses weight after bariatric surgery. I never worry about a patient losing weight after bariatric surgery. What I also noticed, though, is that not everybody maintained their weight loss after their bariatric operation. And it really got me thinking about, well, why is that? Why do we see some people see weight recurrence and some don't? And we can see this in studies as well. So if we look at long-term weight recurrence with a band, it was a little over 50% at the 10-year mark. For sleeve patients, we've seen data come out saying either 30 to 50% of patients will see significant weight recurrence. At the 7-year mark, for bypass patients, that's about 15%. At the 20-year mark, in the best study that's out there, duodenal switch, that's about 5% at the 20-year mark. Now, certainly part of that is as you go down that list there, you increase the metabolic effect in the body. And so as the operation gets more powerful from a metabolic standpoint, weight recurrence tends to be less. So really, this is looking at the different habits of patients that I've taken care of over the last 20 years. And we in our clinic, we'll see somewhere between 1,000 and 1,500 patient visits a year. And so we've gotten a broad exposure to what patients are doing. It's also really talking to lots of colleagues from multiple disciplines. What is the behavioral health aspect? What is the exercise aspect of it? What's the nutritional aspect of it? There's multiple things that started to play a role in this. And then looking at the literature, and there's been a more robust literature over the last 10 years looking at habits and how do those affect us on a metabolic level as well. So I first put together my list of 10 in 2008, but this has not stayed the same. It's been a very dynamic list, and as my observations grow, as new data comes out, then I change it. So it's definitely not fixed in stone. But it forms the basis of our entire follow-up program. So we have 4 one-hour classes that patients attend where we really dive deeper into the topics that we're going to talk about tonight, the 10 prescriptions. And then we work on that through the remainder of the year. Our support groups work around our prescription for success topics as well. So we really try to incorporate it into the entire program. So let's just jump in. And again, normally this is a 4-hour course. I'm really tried to bring it down to the things that are I think most critical for you guys to know. So number one, it's not about fault, it's about physiology. And I put this number one because I think it is the most important thing that anybody who's having bariatric surgery or who has had bariatric surgery needs to understand. Now, you all have probably heard of the energy balance equation that says the number of calories you eat minus the number of calories you burn will determine whether you're gaining or losing weight. So if you eat more calories than you burn, then your body should store those extra calories as fat and you'll gain weight. If you burn more calories than you eat, then your body should burn those fat calories and you should lose weight. Now, everybody's heard of this one, I hope. Well, what we aren't told, and what is really new information, I would say, over the last 5 years, is that when we take in more calories than we burn, our body actually tries to bring that back to even through a process called metabolic adaptation. That's a very complex system in our body that involves our brain and our pancreas, our gut hormones, our fat tissues. All of these are constantly talking to one another to try to regulate our body weight. And so when we take in too much, our body actually tries to compensate and bring us back to even. The difference between someone who struggles with their weight and someone who doesn't struggle with their weight is how good is their body at bringing them back to even. So for someone on the scale that you see, the +2 calories a day, their body's really good at bringing them back to even. But the person who really struggles with their weight, their body is not as good at pulling them back to even. And it's not a huge difference in terms of the number of calories that takes to see a significant amount of weight gain over time. Again, it's not about fault, it's about physiology. What drives that? Genetics. We know today somewhere between 50 to 70% of somebody's weight is related to genetics. What you're born with makes a huge difference of whether you're going to gain weight over time, significant amount of weight, I would say struggle with your weight, or not struggle with your weight. As someone who maintains a healthy weight, I can promise you I am not the perfect eater. I don't exercise every single day, but I can maintain a healthy weight. Why? Because I got good genetics. I got lucky on that genetic profile. My body's really good at pulling me back to even. Now, as I age, I have to be much more careful than I did certainly when I was 21 or 22. But my body's still really good at keeping me even. It is critical that patients remember surgery does not change your genetics. Absolutely does not change your genetics. At baseline, it's still a calorie balance issue for you, and it still is after surgery as well. But now that you know that, we can start to make a difference, right? Surgery is going to reset the weight. It's a do-over. We can get you back to a healthier weight, but at baseline, you still have a calorie balance issue. So we can't fix the past, but now we can impact the future by knowing that. We got to get rid of blame. We got to get rid of shame about it. What we want to replace that with is responsibility and accountability, because now we know what the baseline issue is. Let's take control of it. And that's where the rest of these prescriptions come in. One of the critical things in our program is that you start to recognize physical hunger versus mental emotional hunger. So I have this cat, and this is my cat and my dog. I've had them forever. And if you guys are animal lovers, like I am, you'll know that once you've had animals for a while, you kind of know what they're thinking, honestly, by the way that they act, the sounds that they make. So this cat, every single time she's hungry, she has this particular meow that she makes. And so dog's the same way. The dog has this little growl. You know he's hungry. So every time that cat makes that meow, now that I finally figured it out, I'll go get a bowl of food and I'll give it to my dog. Well, the cat starts making that meow again. So, okay, fine. She's still hungry. I'll go get another bowl of food and I'll go give it to the dog. Well, I took my dog to the vet. You know what the vet told me about my dog? What are you doing to this dog? You're overfeeding him. None of you guys would do that. I know that sounds crazy, right? But think about what we do as humans. We're bored, we're stressed, we're angry, our cat is hungry, and we feed the dog, right? That is physical hunger, mental emotional hunger, right? And it's critical that we figure out, is this my head telling me I'm hungry, or is this my body telling me I'm hungry? And by starting to separate those out, now when I know this is mental emotional hunger, now I can deal with the mental emotional hunger. I can develop skills to deal with that. But until I separate them out, that becomes very, very difficult. So we use the acronym THEEF in our clinic. THEEF are your physical hunger cues: trouble concentrating, headache, irritability, empty feeling, fatigue. The 5 good physical signs of hunger. And we think of your hunger like a gas tank. So when you get in your car, you turn the tank, the ignition on, a tank goes up to full. That's when I'm not hungry. But as you're driving around, as you're going through your day, you're burning energy, that tank starts to fall. And when you get kind of into that quarter mark tank, you'll start to get those early hunger cues. The earliest hunger cues are typically going to be just kind of this empty, gnawing feeling that won't go away. I can drink liquids, but again, unless those liquids have calories, it's not going to make true hunger go away. And because hunger is the sign that our body's needing fuel. We got to bring fuel into the system. So empty feeling, trouble concentrating tend to be the earliest signs of hunger. The next one, as the tank, if I don't fill my tank, it continues to fall, then it's going to be irritability. That's sort of that hangry sort of stuff that people talk about. That's a hunger cue as we move down. As I start to get towards the empty mark, that's going to now be fatigue, headache are the most advanced signs of hunger, where I've just got no energy to do anything. Remember, your brain, the only fuel your brain can use is sugar. So when our blood sugars drop low, that's when we get the headache. That's a very advanced sign of hunger. And so when we're at that mark, that's when we're almost at the empty mark. Empty mark's hypoglycemia, right? That's that shaky, oh my God, get something in before I die sort of feeling. And we don't want to get to that point, right? That's where we make horrible food decisions. I'm just going to put in whatever, makes that feeling go away. And so, again, it's starting to recognize these cues. And then if I'm hungry, I stop and I eat, right? That's the way you fix hunger. But recognizing it becomes key. Hunger is a driving force for mankind. And so we have to control hunger. That's what surgery does really well. That's what we do with our medical patients, with the medicines we put them on, is we really try to control hunger. That can wane over time. And so if you're finding I'm 2, 3 years out from surgery and my hunger is really starting to come back, there's things we can do for them. And again, why you need to stay in touch with your program, because we can control the hunger. If you don't control hunger, people will seek out food. It's important to keep in mind too that your normal hunger varies. So some days you might be hungry 3 times, but the next day you may only be hungry once. That's normal hunger. The key really remains, if I'm hungry, I need to eat. If you think, oh man, I'm hungry, and you go through your physical signs and you don't have any of them, by definition, that is mental emotional hunger, right? It's not physical hunger. That's what allows you to take a moment to say, okay, well, what's going on? Am I bored? Am I stressed? What is this cue that's making me think that I'm hungry? Because then I can start developing some strategies to deal with that. Some common ones that I encourage patients to do is to put signs up in what I would say are strategic locations, that being your refrigerator, your pantry, where your snack jar. Put up a sign that says, am I hungry? Why are you here? Just something little that makes you stop for a second to say, do I really want to do that? You may still do it, but again, at least it gives you a stopping point to say, let me see if I really want to do this. Food journaling often helps too. If you find yourself, I'm just kind of eating to eat, to start food journaling and say, okay, when I'm eating, why am I eating? What is it that's making me want to eat? And ultimately want that to be because I'm hungry. I think one of the most important things is just keeping that food environment clean. Out of sight is out of mind when it comes to food. And I tell patients all the time, listen, if you want something so bad that you're willing to get up at 10 o'clock at night and go drive to the store to get it, I can't fix that. I can, but it's going to be a lot more work. It's way different than I get up and I just go to my refrigerator and I get it. That's very different. So by keeping that food environment clean, keeping those things away from you that are really, really tempting can help you develop that willpower. Willpower is a muscle that has to be flexed and has to be worked in order to grow. And the more that you flex that and work that, the easier it becomes to have that willpower to say, I don't think I want it. The other thing I encourage patients is have a pre-planned alternate activity. What that means is, if I know I'm emotionally hungry, I'm going to go do this. And this may be a crossword puzzle. I'm going to call a friend. I'm going to play a computer game. I'm going to do something on my phone that distracts me from that emotional hunger. Because I know it's not physical hunger. And oftentimes, if I can just get away from whatever that thought is, that hunger, that emotional hunger goes away. And then lastly, get professional help. There's nothing wrong with seeking out some help to deal with a particular emotion. If I'm not able to control it myself, let's get some help, some more professional help to do it. All right, prescription 3. When it comes to eating, choose persistence over perfection. One of the hardest things I think to do particularly for my bariatric surgery patients is getting them out of a diet mentality. And that diet mentality is that, oh, I can't have this, I can't have that. I want to get out of that, because we can really fit anything into a good, healthy diet if we get the quantity and the frequency right. That's the key. So if I have a patient who says, oh man, I love hamburgers, and I say, don't ever eat a hamburger again, it's never going to work. What'll happen is they'll come back to clinic and then they just won't tell me they're eating hamburgers, right? So let's talk about, well, how do we fit this in to your good, healthy diet? Because it can fit into your good, healthy diet. And so I don't talk about good foods and bad foods. I just don't believe in that concept. I do believe in good choices and not so good choices, but I don't believe in good foods and bad foods. And so we have to figure out how to work what you like into your eating plan. And again, we don't talk about diets. We talk about eating plans. What's your eating plan? And then that goes into what my 10-meal theory. My 10-meal theory is that you take a tray of food and you fill it with the worst possible things that you can think of, and then you eat it all. In your long-term weight loss journey, it makes zero difference. The 10 meals before that one, the 10 meals after that one make a much bigger difference. It's about creating consistency, not perfection. We don't have to be perfect eaters. We have to be consistent eaters. In general, I make good choices. Not every time. We don't have to make good choices every time. Cravings certainly can be an issue, and cravings vary for patients. Some people have sweet cravings, some people have salty, crunchy cravings. A lot of that becomes ritualistic. So every time I watch TV at night, I grab some popcorn. It's a ritual of me sitting down, and those can be worked on. For the really bad cravings, we have good medicines now that people can be placed on that can really knock down those cravings as well. And so if you're really struggling with cravings, I encourage you to talk to your program because there's things that can be done with that. Carbs always comes up. I am not a program that we say we are not a no carb program because I think that's just not realistic. Apples have carbs. So we're going to say don't eat an apple? No, it's really getting better carbs and looking at the simple carbs versus the complex carbs. So a simple sugar versus a wheat, right? So the more complex you can make your carb, the better off you are. Because remember, when carbs break down, carbs are basically sugar molecules linked together. And as they break down, those sugar molecules are released. The more complex the carb, the harder it is for that to be released. And so we want to try to get a more complex carb versus a simple carb. So if you can do a red potato or a brown potato more than a white potato, better choice. But what if I'll talk with my patients about, I like rice. We're in South Texas. Everybody eats rice. So are there better options within that? Yes, there's much better options within that. And so I don't care if you eat rice. I would prefer you do a brown, long grain rice than a white rice. But what if you don't like long grain brown rice? Don't eat it. That's fine. Eat the white rice. But again, it's quantity and frequency becomes there. In general, what I advise is less than 100 grams of carbs a day is really kind of the goal I think that people should shoot for to help you maintain your weight loss long term. Number 4, liquid calories and snacks are like annoying people. Avoid them. Definitely. These are 2 of the big ones for sure. There is absolutely a clear link between the number of liquid calories you drink and weight recurrence. No question about it. And so the goal for me every day for patients is to try to keep that liquid calorie number as close to 0 as you can. Because when we do a 24-hour dietary recall, nobody puts their liquids because you just don't think about them as being, playing a role in what you take, but they absolutely play a role in your total caloric intake for the day. And a lot of times it's going to be little things that people don't see and get caught up. Coffee is a common one. And so, if you're putting a creamer in your coffee, if you're using the little cups that you peel off, you know exactly how much is in there, but most people don't. Most people will just do the free pour in. Every single one of those little cups has 15 to 25 calories. And so if we're pouring in, now it could be 100 calories for a cup of coffee, which is no big deal. That's fine. But if I have 4 cups of coffee in a day, you can see where these things can start to add up. So it's just something that we have to maintain and be aware of. Sodas for us, I get asked all the time, diet soda, regular soda, which one? They each have their own problems, I would say. What I will say is that if you're going to have a soda, I would rather it be a diet soda or a zero soda than a regular soda, just for the calories. Calories alone, I will take the diet soda over the regular soda. However, there was a fascinating study that honestly didn't get a lot of press, looking at what happens in people, and these were not bariatric surgery patients, these were patients who had never had surgery, but they looked at what happens when you drink a diet soda and eat a carb same time. So you're having a meal, it's going to have a diet soda, it's going to have carbs. And it was fascinating. They were able to radio label the carbs. And what it appeared is that when you were drinking a diet soda, the diet soda, the sweetness of the diet soda started to fool the body, and the body would take the carb and store it as fat at a higher rate than if you didn't do it together. Does that make sense what I'm saying? So if you drink your soda while you're doing a carb, it confuses the body, so the body stores the carb as fat, where it would not do that as much if they weren't taken together. So what I do tell patients is if you're eating please don't, especially if you're having a carb, don't drink a diet soda. Then I would rather you do it between meals and still keep it minimum, is what I would say. But do I care if a patient has a diet soda now and then? No, could care less. There's absolutely zero evidence that drinking a diet soda or regular soda, the carbonation in that causes your pouch to get larger, your sleeve to get larger. That's completely nonsense. And so I don't worry about that part of it. But I will tell you, diet sodas and regular sodas each have their own sets of problems. Alcohol is another thing I get asked about quite frequently. Again, in my program, I am not one who says you can't ever have alcohol. I think you have to pay attention to the calories that you're getting in. And what tends to happen when we have alcohol, we have food. The two go together. And as I drink, I am less worried about what I'm eating. And so your caloric intake can really start to increase that day. And so what I encourage patients is, you're going to, dinner on a Friday, you're going to have a couple glasses of wine. You got to really pay attention to what you're eating earlier in the day, right? I need to save some of those calories for when I'm going to go out that night, because I tend to take in a few more if I'm drinking. What about snacks? So I think about snacks this way. When you get in your car and you turn on your car and the gas tank goes up to full, how many of you look for the very next gas station you can find? I would say probably not many, because your tank's on full. Think of that the same way you would think of a snack. If I am not hungry, I have to ask myself, well, why am I putting in fuel when my tank is full, right? That's what a snack is. So I think a reasonable time to snack is a bridge to a meal. So I'm starting to get hungry. I'm getting some of those early hunger cues that may have trouble concentrating, kind of a little bit irritable, but I don't have time to sit and eat right now. That's a reasonable time to have something small that kind of fills you to the halfway mark until I can actually sit down and eat my meal. That's a bridge to a meal. Should be protein-based. More importantly than anything, you need to portion it out. It is so easy to put some sunflower seeds on your desk, and I'm just kind of throwing a few in here and there, sort of thing, not really thinking about it. And before I know it, a significant portion of that bag has been eaten. Does anybody know how many, you'll have to check the chat and see if anybody knows, the number of calories sunflower seeds have, a cup of sunflower seeds. How many calories are in one cup of sunflower seeds? I was shocked and discovered it because one of my patients is a truck driver, and he has done great. Came back and he was seeing some weight recurrence. We're going through everything. I'm like, man, you're doing everything right. What about when you're driving? Are you doing anything different? He's like, no, I'm staying away from snacks. I'm just using sunflower seeds. I'm like, here we go. That's where it is. So I'll be curious at the end. You guys tell me what the number of calories in sunflower seeds, and don't look it up on Google while we're here. Number 5, when it comes to exercise, live neat, but strive for 5. 3 ways our bodies burn calories: your basal metabolic rate, your non-exercise activity called your NEAT, and exercise. Those are the 3 ways our bodies burn calorie. The 4th way is a very small, that's the energy that we use to digest our food, very small portion. The main drivers: basal metabolic rate, non-exercise activity, and exercise. So which of them do you think in your own head, or you can put it in a chat, when you look at your daily caloric burn, which of the 3 of those is responsible for the vast majority of your caloric burn every single day? It's your non-exercise activity thermogenesis, or your NEAT activities. Number 2, your resting metabolic rate. So almost 80% of your caloric burn every single day comes from non-exercise types of things. Exercise is responsible for only about 20% of your caloric burn. It's an important 20%, and I'll hit on that. But if you really want to increase your daily caloric burn, increase your NEAT activities, your non-exercise thermogenesis. Those are things that we all talk about all the time. Those are the calories we burn just going through our normal daily life. Parking further away, taking the steps, you guys can't see, but I'm at a standing desk right now. So I'll stand between patients because most of us have a desk job now. And by standing up during the day, you actually burn more calories than when you're sitting. And you don't have to stand all day. Just stand up every 5 or 10 minutes and then sit for the next 60 minutes. It makes a difference. And all of those things add up over the course of an entire day, increasing that NEAT score. One of the things to think about, though, is that what happens to our resting metabolic rate and our non-exercise activities when we lose weight? Well, now that I've lost 70 or 80 pounds, when I'm out doing my walking, it doesn't take as many calories to do that same amount of walking, right? It's like you drop an 80-pound backpack. How many calories are you going to burn? A lot less. As we lose weight, it is also natural and normal for us to lose some muscle mass with that. When we lose muscle mass, we start to lower our resting metabolic rate as well. So as we lose weight, we start to decrease the number of calories we're burning. How do we keep that up? We have to exercise. No question about it. You have to exercise. Lots of benefits of exercise. I've listed some here, but a couple that I really want to point out. One, better appetite control. Two, you help build and maintain your muscle mass so you can keep that resting metabolic rate at its baseline level or see less of it go. Improved sleep, better stress management, improved weight management. And when we look at long-term studies of those who keep weight off and those who don't keep as much weight off or see weight recurrence, time after time after time, the number one thing that jumps out is exercise. The people that are exercising regularly tend to keep it off longer. How much do I need to exercise? That's a little bit more difficult question to answer. The simple answer, really, 150 minutes is what we need. 30 minutes at least 5 times a week is ideal. I will tell you those numbers are actually going up. And I think we're going to see increases in the amount of activity that we need to be doing on a regular basis. And again, those 30 minutes, it doesn't matter if you do 30 minutes straight or you do 3 10-minute sessions. They've been shown to be equal in terms of your number of your caloric burn. And so finding little times that you can do activity is just as important. Critical slide. You will never, ever, ever out-exercise a bad eating plan or a bad diet. You have one chocolate shake, you got to go walk for at least 68 minutes. So it's always in conjunction when I'm making better food choices and exercise is ideal. If I had to choose one versus the other, I want you on a good eating plan, right? I want you on a good eating plan, increase your NEAT activities, and then I'm going to talk to you every single time and get you encouraged about getting out to exercise. Number 6, sleep your way to better days. This is probably one of the biggest areas of research over the last 3 years and how much we've learned about how critical sleep is in weight control. Multiple studies now have shown a dose-response relationship between sleep and weight, meaning that the less you sleep, the higher your weight is going to be. The more you sleep, the better your weight is going to be. Why is that? This is being looked at very strongly right now. What we see on the day after somebody doesn't sleep well is an increase in their total caloric intake of almost 20 to 30%. They want to eat those higher calorie foods. You guys probably remember this if you've had a deadline at work or when you're in college and you were staying up all night doing that study, you're kind of snacking along the way to help you stay awake. And then the next day I get my test and I'm like, oh, that's when I want to go and get that higher calorie food. Tend to have larger portions. And importantly, when we look at hunger hormones, they go up when we don't sleep well. And so when somebody's having trouble with their hunger, they feel like their hunger is coming back. One of the things we talk a lot about is how are you sleeping? Because if we can also help control that a little bit better, we can get that hunger controlled. The other interesting thing, and this is really not well understood, is that the next 24 hours after the day you don't sleep well, your energy expenditure goes down. So now you're in the worst of both worlds. My calorie intake goes up, my energy burn goes down. You can see why that occurring over a long period of time, people can start to see weight going up. What is good sleep? Most studies will show that adults need about somewhere between 7 and 9 hours of continuous sleep over a 24-hour period. That is highly variable. Some people function perfectly on 5 hours. Some people need 10 hours. And that's kind of you figuring out when am I at my best. But falling asleep within, you should be asleep within 15 to 20 minutes when you lay down. And then if you wake up in the middle of the night, should be back asleep within 15 minutes. When you wake up in the morning, you should feel rested. You should feel like you got a good night's sleep. And if you don't feel rested, you didn't sleep well. And certainly if your partner's telling you, oh my gosh, you just move all over the place, or your snoring is super loud. Again, those are all signs that you're not sleeping well. Keep in mind sleep apnea. Many patients who struggle with their weight have sleep apnea. When you lose weight, many people will see their sleep apnea go away, but not everyone. So if you find that you're not sleeping well, you had sleep apnea, you lost weight, but I'm still not sleeping well, you may still have sleep apnea. And it's worthwhile getting a sleep study, because oftentimes you won't need as much or as strong of CPAP, but you still need the CPAP in order to sleep. I think it is perfectly fine to use meds to help you sleep. But oftentimes by cleaning up the sleep habits, as we'll talk about, you will become a better sleeper. If you are age 40 or above, or you're a postmenopausal female, think about hormones, hormone replacement. The number one thing that we see in patients, and we do hormone replacement therapy as well, the number one thing that people complain about when their hormones are off: sleep, fatigue, loss of libido. The three biggest things. That's fixable. That's fixable by simply replacing some hormones. And as we all age, it's natural for our hormones to start to decrease. And by getting that replaced, we help you be a better sleeper. 3 cues our body use when we go to sleep. So when we talk about sleep hygiene, or just kind of cleaning up your sleep habits, here's some simple things you can do that'll help you be a better sleeper. The 3 cues our body use: position, light, and temperature. Position being when you're in that laying down position, you need to get your body to understand that when I go into this position, I should be sleeping. And so our bed, sleep, and sex, the only thing we should use our bed for. It's not for napping. It's not for watching our phone. It's not for reading. Those things need to be done outside of my bed. I want my body understanding that when I get into bed and I go into this position, I'm ready to go to sleep. It gets it into that habit. It is critical that you try to keep a consistent sleep schedule. This is why people that do shift work, it's so hard for them, because they can never get on that regular sleep cycle. By getting on a regular sleep cycle, again, you're preparing your body that when it's around this time, this is when I would normally go to sleep. And you can't pay back your sleep debt. So if I sleep 2 hours tonight, I can't sleep 10 hours tomorrow night and make up, right? That lack of sleep for the next 24 hours throws my body off. And so I want to try to get consistent with my sleep schedule. Data with naps is all over the place. And so what I encourage my patients is that if you're going to nap earlier in the day, or just don't nap at all, because it certainly can throw your sleep cycle off at night. Simple things: avoiding caffeine, nicotine, chemicals, alcohol. Some people think, oh man, I sleep so much better when I'm alcohol. You will fall asleep, but you never get into the deep, restful sleep. You never get into that REM sleep. So going into stage 3, stage 4 becomes more difficult when you have alcohol on board. And so yes, you will sleep, you won't wake up as rested. That 64 ounces of fluid that we always talk about getting in, try to do it earlier in the day so you're not waking up to pee all night long. And then exercise and shower. This is the two, some interesting work has been done around this. This has to do with body temperature before you go to bed. And you want that body temperature as low as you can because that's one of the cues our bodies use to know that we're ready to sleep. And so if I take that hot bath and then try to lay down, it actually makes it harder for my body to go to sleep. I feel a little more relaxed, but in trying to get into that more deep, restful sleep, it prevents me from doing that. So you want to shower, an hour or two ahead of time, so your body has your core temperature has some time to cool down before you lay down. The most important thing is getting into a pre-sleep routine. I see this all the time with my moms. I cook dinner, I clean up, I got to get the kids ready for school, I got to get myself ready for tomorrow. Okay, I'm going to lay down and go to sleep. It doesn't work that way. Yeah, that sort of crazy time just doesn't prepare your body to be able to sleep. So you really want to have 30 to 60 minutes before I'm ready to actually go to sleep. I call that your wind down phase, where I'm really kind of settling down. I'm starting to bring the lights down so that my body understands I'm thinking about I'm ready to go to sleep, or I'm getting ready for sleep. And there's data all around, smells and scents and that sort of thing. My kind of gestalt feeling about that is that if you think it helps, it probably does. And so if you like lavender in your room, it probably helps. You got to figure that one out on your own, but you definitely want your room cool for sure. If it's hot in there, it is much harder for you to be able to go to sleep. And when you're in that sort of wind down phase where you're again thinking about, okay, well, what do I have to do tomorrow? All of that sort of stuff. That's the time you want to do that, not once you lay down. Because once you lay down, you want to be asleep within 10 to 15 minutes. If it's time, okay, now I've had my wind down period, I just don't feel sleepy yet. Don't get into bed. You will start to just frustrate yourself. I'm laying there, I can't go to sleep. I want to go to sleep. Why can't I go to sleep? You're better off sitting up. Remember, when you're in this position, you want to train your body that I should be asleep. So if I'm not asleep within 10 to 15 minutes, I want to get back up out of bed, do some quiet activity with minimal light, and until I feel tired. And then when I feel tired, that's when I want to lay down again. And this is not something that works, in a day. This is something that you got to get into these habits, work on these, and you start training your body. And it becomes much, much easier to be a good sleeper. There is no stress less, but there is stress less. This is probably the second area in the last 5 years that has become much more understood, the effects of stress on our weight. And it's important to think about acute stress, chronic stress. So acute stress would be, I pull a gun on you and I say, give me your money. That sort of feeling. That's acute stress. That's not what we're talking about. What we're talking about here is chronic stress. My work, my kids, my school, my bills, all of those things that add stress in our life. That's what we're talking about. When you think about stress, I want you to think about cortisol. Cortisol is that main stress hormone in our body. And the majority of our stress receptors are actually in our belly, in our intra-abdominal fat. So when those cortisol levels are raised, chronic stress, we tend to accumulate fat around the middle, our intra-abdominal fat. That's the fat that leads to high blood pressure and diabetes and sleep apnea, the significant metabolic fat right around our middle. That's where your chronic stress tends to see weight gain. It also affects your food choices. So when I'm under chronic stress, I start increasing my hunger hormones. You can see those numbers come up and it makes me snacky, right? I kind of want to go grab something, which oftentimes just leads to old habits where every time I had stress, I would eat, and I start falling back into some of those old habits again, that mental emotional hunger, right? How did I deal with that? When we're under stress as well, we don't make good food choices. We go for those comfort foods, right? Those are those energy dense foods that we remember being palatable and made us just feel better, right? That's what we tend to want when we're in that stressful mood. If you've ever, you got a big deadline coming up and you're I'm working all night trying to get this done. You're not thinking about carrots, right? You're thinking about, oh, let me get a candy bar or some ice cream or something. Chronic stress also affects all the other areas. And so we don't sleep well when we're chronically stressed. We don't tend to want to exercise when we're chronically stressed. Many people will use alcohol when they're stressed. So it starts leading into this vicious cycle of things, none of which are good for weight maintenance. Here are just a few different stress reduction techniques that are out there. If any of you in the chat know which one of those has been considered the best stress reduction technique that's out there, of those that are listed there, I guess the trick is whichever one works for you is the best. Is what the studies show. There's no difference between any of them. It's which one works best for you. And so if you try one, doesn't seem to be working very well, try a different one. These are all some simple ways. When we talk about reducing stress, again, I don't want to make it sound like you're going to be stress-free, right? You're stressed less, right? You're not stressless, you are stressed less. It's giving yourself these little mental breaks during the day where it just seems a little overwhelming. Let me stop for, I will give you just what I do. So probably maybe once, twice a day, especially when I'm in clinic, where it's just chaotic, where things are just going crazy. I walk into my office, I'll turn the lights off, I'll sit for about a minute and just do some deep breathing, box breathing. If you ever called it box breathing, breathe. I can do that for about 45 seconds. I'm good. I'll go out and back again, ready to go. Next 3 hours, if it's still crazy clinic, I might have to come in and do another box breathing, right? What's going on at home? If it's crazy at home and crazy at clinic, okay, I may be in here 3 times. It's giving you little breaks, right? Just little breaks during the day that starts to bring down that cortisol level. Not trying to get you so you're stress-free, trying to get it so you're stressed less. Number 8, give me the best medicine or no medicine at all. Couple of things I want to say before we dive into this. Please do not stop any medication you are currently on because of something you hear right now. All right. So you could talk to your physician about a medicine, but don't just stop a medicine if you see it as we talk about it. What I want you to walk away from this is remembering 2 things. One is the term weight neutral. For every single medication that's out there, in that category, there is a weight neutral medication. That's what we want to look for. Because in a group of medications, many of those medications may cause weight gain, but there's always one that is weight neutral. If we have weight gain with the medication, it's not for the entire life of the medicine, right? Generally, it's in that first 3 to 6 months when you start the medicine. Most medicines, if they lead to weight recurrence, it's in that 5 to 20 pounds. It's not 100 pounds that someone's going to gain on a medicine, usually a little bit smaller than that. And it's when you start the medicine. It's not while you're on the medicine the entire time. It's usually an upfront weight gain, and then it stops. And for any medication, we have to weigh that balance of weight recurrence versus the benefit of the medication. If the medication benefit outweighs the risk of seeing some weight recurrence, it's better to be on the medicine, right? Just a couple of things to keep in mind. So here are broad categories of medicines that are absolutely associated with weight gain or weight recurrence. Antidepressants are classic for this. Antipsychotics, classic for this. But within each of these categories, again, there are weight neutral options that are there. What if I have tried a couple antidepressants that are weight neutral? It's not working. Then we got to get on one that might cause a little bit of weight recurrence. Again, untreated or unmedicated depression has its own set of problems, right? That can lead to weight recurrence. I don't sleep as well. I don't want to exercise. I don't want to participate in life. just as bad as seeing a 5-pound weight recurrence being on one of these medicines, right? That's the balance that we ultimately try to reach. A couple of the big ones here for sure, steroids. If you have to go on steroids, you have to go on steroids. We try to keep it as short a period of time as possible. When you're on steroids, your hunger just goes crazy. It's basically like giving you cortisol, right? So it will drive those hunger levels. It will make you want things that you normally don't want in terms of foods. So we try to keep the lowest dose for the lowest amount of time. Diabetic meds are classic for this. Luckily, most patients, when they lose weight, are coming off of their diabetes medicines. Beta blockers, the antihypertensives, that whole group of beta blockers associated with weight recurrence. One that most people don't know is Benadryl. A lot of people will use this for sleep. They want to try to go to sleep, they'll take some Benadryl. Chronic use of Benadryl absolutely associated with weight recurrence, particularly in that first 3 months if you're doing it regularly. All right, number 9, surround yourself with positive people who will keep you accountable. We call this the take out the trash prescription. When you are in a healthy relationship, it should do these things for you. It should certainly nurture your soul, bring you joy and peace, enhance your life, provide safety and stability, or a feeling of safety and stability, and it should help keep you accountable. That's a good, healthy relationship. After any time, whether you're having medical weight loss, surgical weight, it doesn't matter, any time in your life, I think you need to look at the people around you and say, are they meeting that? Are they doing these things? Is this relationship doing this for me? If it's not, take out the trash. And again, I think that is true in all of these groups of people, all right? We can have toxic relationships with our spouse or our significant other. We can develop toxic relationships with our children. And I see this so frequently in my patients over age 60, 65, where the kids are moving back into the house and it's disrupting their entire life, and learning to set some boundaries around that as well. I am definitely not one who says, don't give somebody a chance, just get rid. No, talk about it and talk about why this relationship isn't working well for you. And let's see if we can work on it. But ultimately, at some point, you got to say, I got to take care of myself here as well. If this relationship is making it very difficult for me, it's probably not worth it, right? So we have to look our entire circle as well. Take out the trash. No need to have it around. Lastly, never, ever, 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 ever forget where you started. I think that's critical. So all of us remember this picture, right, in our weight loss journey, that, oh man, that was so amazing. I feel so good. This is great. What I want you to remember is this picture. I want you to remember what that was like. And so as we move into that maintenance phase where I've gotten to that weight that I've wanted to, or that good weight that I'm at, studies have shown it is important to weigh frequently. What I encourage patients after their first year to weigh every day or every other day, not putting any sort of importance on any one day, right? So you always want to look for trends is what you're looking for. It is normal once you've gotten to your new healthier weight to bounce around. 5 up, 5 down is normal. So if your ending weight is 170 pounds, it's normal to be 165 to 175 and kind of just bouncing around within there. What you want to watch for more is if I'm seeing 172, then the next week it's 174, the next week 174, another week 175, and we're kind of seeing a trend of things, right? Then I got to say, okay, what's going on? I'm doing something different. Let me look at it and see what I'm doing. Keep that pre-op picture in a visible place for yourself, but in a private place. You don't need to share it with everybody, but I do think it needs to be something that you're going to see on a regular basis because it's a reminder. It's a reminder of where I started, both from a celebratory stance, look how far I've come, but also of look where I could go, right? And it's possible to go back. How do I prevent that? And that's what we talk about. We talk about a remembering exercise and a celebration exercise, and they're really done at the same time, where I just kind of having a quiet period of time where I want you thinking about, what did it feel like when I was at my heaviest? How was my breathing? How was my pain level? How was it when I walked? All of those feelings, think about them again. Where was I at? And then bring it back to, where am I now? What do I like about now? What do I like about the weight that I'm at now? How does it feel now? How did I feel when I got to that weight, in terms of the joy that I felt, the hard work that I put in, right? I think it's important to keep both of those things in mind. If you have a bad day, whether that's an eating day, an exercise day, any day, I have a bad day. It's just a day. It's just a day. Tomorrow's a new one, and I get to start over again, and I can have a good day, right? And when I see patients get off track, it tends to be that they're starting to get off track, but never quite able to pull themselves back or reel themselves back, and then eventually it's just forget it. Rather than trying to do everything at once, let's start on one thing. What do we want to do this week? I'm going to work on lowering my carbs this week. That's what I want to do. And let's do that every single day. Pay attention to it. This is what I'm going to focus on today. Now, next week, I can start to add something, but sometimes it just becomes overwhelming. If all of a sudden I'm like, okay, well, I'm not exercising, I'm not eating right, I'm not sleeping right, I'm so stressed. It just becomes too much, right? So every day is a new day. You have a bad day, so what? In your long-term success, it makes no difference, right? It's your consistency. Get into a consistent pattern. And then there's no shame in getting help. I remember prescription one, right? Not about faults. It's about physiology, right? And so we have to keep that in mind. If you have knee surgery, and your knee's better, you're feeling great, and now all of a sudden, man, that knee's starting to hurt again. Where do you go? Well, usually back to the orthopedic surgeon and say, man, my knee's hurting. Well, why is the same not true if you're seeing weight recurrence, right? Where do I go? Well, you should go to your bariatric program, is where you should go. That's where you want to be. That's who can help you get back on track. Or maybe we need to add some medications, or maybe we need to work on some habit types of things. I tell patients all the time, it is easier for me to help you take off 5 pounds than 50 pounds, right? Don't wait till 50 pounds. Come see me at 5. You're not gonna hear your bariatric surgeon get mad. You're not gonna hear them be, oh, I'm so disappointed in you. No, that if they say that to you, they shouldn't be doing this business. Honestly, it's not about fault. It's about physiology. We've got to keep the physiology under control. And we think of this now more as like the cancer care model, right? So when we operate on somebody for cancer, we can get it controlled, but it is certainly possible for that cancer to get out of control again. And what do you do then? Well, you add additional treatments, right? The same is true for weight. And if we find weight getting out of control, then we have to escalate therapy. And for some patients, that may be they had a band, and the band just wasn't the right tool for them. And so we've got to get them a better tool. So maybe that means converting them to a bypass or a sleeve. Maybe that's taking them to a duodenal switch. Each of these operations has a different effect in the body, a different metabolic effect. And sometimes some people need a more powerful effect. It doesn't mean you failed. That means we need a better tool for you. That the tool worked for you for a period of time, but now we need to increase therapy. We need to make it work a little bit better for you. This is where I think support group really becomes helpful long-term to remind you where you started. That once you're 2 years, 3 years, 4 years out, a lot of times patients don't want to come to support group anymore, and I get that. And I don't know that they necessarily have to come every month, but it's great to check in at least once a quarter. And you'll see people who are at the very early stages of their journey or people who haven't started their journey yet. And it reminds you of where you came. It reminds you where you started and how much hard work you put in and why it's so worth continuing to put in the hard work to maintain that good health. That is as fast as I could go through 10. And so I am happy that I opened it up to questions. I know that was a whole lot, and I hope you enjoyed it.
I feel like it was amazing. In fact, it was out of doing a lot of these support groups for a lot of years, I feel like a lot of what you said was a little bit off the normal, meaning it's not the typical remarks that you get when how do I, what are the major factors of success and how do I stay on track and all of that kind of stuff. Because you kind of went into the being realistic, and I love that just being real, because all of us are human and we all have many different factors to consider. We do have some questions, have a lot of comments coming in still, and I think what I want to do is, I know some people may have to jump off early. So I do want to say, because I want to get to, if you're agreeable, we can definitely do some of these questions. But what I'd like to do is number one, to kind of give some information on you. Just in case anybody does have to jump off, I also want to say these meetings are recorded. So this will be on replay for till the end of the month, on demand using the same link that you did to access this. We also put all of our recordings on our YouTube channel, which I'll show them here shortly how to access that. And that goes on the Tuesday following each event. So it'll be on demand until the end of the month, but also be put on our YouTube and most major podcast stations. So if you want to listen to the audio portion. There was someone who asked about actually multiple people asked about getting a copy of this. I don't know if that's something you share, because I know you also have a program that you do regarding this.
I'm happy to share it with anybody who's here.
Okay, wonderful.
I can email it to you.
Okay, so we can do that. We'll chit chat after that, and we'll figure out how because we do, when people register for these, they actually give us their email. So we will provide that to everybody that's registered for this live event. If you're listening to the replay and you want a copy, my email is my last name, Hain, Hoehn, my first initial B, at procarenow.com. So you can reach out that way or call our customer service number and we can help you with that as well. And so let me give them, if somebody is, I do want to answer questions. So if you do have a question, put it in the Q&A box, but I also want to say, how can people get a hold of you if they're wanting to connect with you? I'm going to copy and paste what you have given me as far as your contact information, but is there anything specifically, is the best way through your office?
Yeah, email is the easiest way to get in touch with me. And it's just Dr. S, DRS, at Better Way, WEIGH, Center.com.
Okay.
Yep, that's it.
Okay. I'm going to copy that to put into, if somebody is listening to replay, we'll have all of this in the description too as well, so that you can definitely be able to reach out further. And okay, so we got that. And I am going to jump in right now to questions and answers. I also just want to say, Dr. Stegemann, you've been a supporter of ProCare, and I want to mention our sponsor. So I just want to say thank you. Thank you for being a part of that. Dr. Stegemann does have an affiliate code too, so I will share that. If anybody is interested in our ProCare products, I'll jump on our website real quickly. I'll show you where you can access more of these type of events, as well as our products. And Dr. Stegemann, by using his code today, it is 10% off your orders. Code is BWCVIT. And again, we'll make sure and have that in the description of this event in case you're listening to a replay. So I'm going to share my screen just real quickly, jump on, and then we're going to, as soon as I share our ProCare information, we'll jump into questions here too as well. So procarenow.com, copy that, put it in the chat box. What ProCare Health is known for is being one of the lowest price vitamins out on the market. We just came up with a price match guarantee. So if you do find something cheaper out there, you can call our customer service number and let us know and we will price match. We just came out with some new products. Just mentioned briefly here, we have if you've had a duodenal switch, we have a new DS Sadie version that's been up and improved. We have a core, and then we also have an add-on if you need extra ADEK. So that's one of our newer products. And then you can kind of see the screen here changing colors. We have the this top portion of our top of our website. So there's the DS80. You'll see a calcium product that'll pop on here shortly. We just came out with calcium singles. They're little powder that you can put in a drink and add it to that. So that's one of our newer products. Our Citrus Grove has been one of our newer products, and it has been something that people just fall in love with. We also have our Citrus Grove and Purnilla and Peppermint little inserts. Those come free with a 90-day subscription. So you can't purchase those, but if you get a 90-day subscription, you get those. Also, just want to jump over here to Bari Connected. Our Bari Connected tab will give you access to any of the events that we have during the month. We also have a support group handouts page, which we have all of our handouts to our past events. And then under Bari Connected, you can also find a lot of links. You can find a link to our page down here. You can find a link to our events, including this event. So if you want to listen to the replay, you can simply just click on there, or any of our events that we have each month. That changes from month to month. The YouTube link is at the bottom of the page, along with our Facebook and our Facebook group. And then the podcast. So the ProCare Health YouTube channel, we actually now have over almost 400. We hit 399 videos. So lots and lots of replays. So if you're looking for any specific topic, we'll be on there. And Dr. Stegemann segment will be on replay there starting next Tuesday. So I'm going to stop sharing my screen, and we're going to, if you still are able to, Dr. Stegemann, I don't know how you are on time.
I'm fine. I'm fine.
You're okay? Okay, we're going to go ahead and do some Q&A here. So let's go up. Number one question here, what would you recommend to a patient that has tried all things to lose weight, but has literally not lost a single pound? So I'm not sure if they've had weight loss surgery. She said, I've tried TYDI since I was 5. I've used GLP-1s, diet of all different medications with no success. What's your thoughts on surgery? I'm just terrified it won't work like everything else. So you've kind of answered this. This was an early question, but is there anything you'd say to somebody who's like, has that fear still within them? Because a lot of people who are turning to weight loss surgery have tried everything that they can imagine.
The first thing I would say is you're not alone. I mean, a lot of patients, a lot of people don't have great success with different things that they've tried. That has absolutely no predictive ability of how you'll do with bariatric surgery. Because with all of the medications that are out right now, they're really hitting one target is what they're hitting. Bariatric surgery works on multiple targets. And the best guess we have right now is probably somewhere between 8 and 10 different mechanisms are in play that cause the bariatric surgery to work. And so certainly can still do. I have never, ever seen a patient not lose weight after a bariatric operation. It can be variable, the amount, but I've never seen a patient who didn't lose weight. And so, it offers, it can work for you. It definitely can work for you is what I would say.
Well, and I think you have a good point there too. I had to ask myself before I had weight loss surgery back in 2013. I had to ask myself, How is this going to be different? But it is somehow it's metabolic surgery. It's,
It's
there's
not,
just so many other factors involved. So hopefully,
yeah,
Lindsay, we help give you some reassurance.
that's where our understanding has gone to. Again, it's what these operations are doing is working on a physiologic level. It's not a you just eat less. It's working on a physiologic level, and that's what's causing the weight to reset. And like I said, I personally have never had a patient. I operate on over 4,000 patients. I've never had a patient not lose weight. I don't worry about that. Honestly, I worry about, are we going to see weight recurrence? Right? That's why we got to work on all the habit part of it as well, because the genetics don't change.
Absolutely. Dr. Stegan, there's a couple questions here that I want to make sure we get to. It's somebody says, are we able to attend your monthly support groups? Do you have?
So we still do it old fashioned. We do it in person. So if you're in Corpus Christi, you certainly can. Is what I would say. We don't do it. We don't have an online one. We still do them in person.
Okay. How about that 4-hour class?
Ooh, now that's a good question. So we do that by Zoom. I've never thought about it. I have to think about it. I don't see that. I can't even problem with it. I have to think about that a little bit. Because again, it's there's a little bit of HIPAA stuff around that, because those are our patients that are in there as well, and how they would feel about it. I will think about it and get back to you. How about that? Is that fair?
That sounds good. Yeah, we appreciate that. So normally, like what the information that you're providing is patients that have surgery through your surgical weight loss program would typically go through this post-surgery or pre-surgery, is what you're
Correct.
saying. Okay,
Correct.
gotcha.
So
Okay.
we use it in our pre. So when we're starting to see patients, our pre stuff is starting to introduce some of these concepts. But again, a lot of the concepts don't become real to you until you've had surgery, right? Where now I don't feel hungry anymore, right? Because my surgery is helping take care of that, and then I can start to separate out what is my head hunger versus my physical hunger types of things. So we use it primarily, the program, for our post-surgical patients.
We have a couple on weight loss and plateaus. One of them, I'm gonna kind of group those together. So one says how to overcome a plateau, because I think we can how to overcome, let's see, jumping down. Healthiest way to get back on the program when a patient has had a month of getting away, how to get back on the bandwagon, more or less not eating enough through the day or not eating enough protein vegetables, feel out of control. So plateau and healthiest way to kind of get back on board.
Those are a couple of important points. And so and plateaus, I'm going to talk about bariatric surgery patient plateaus, because it's a little different for medical patients that haven't had surgery. It's a little bit different. One of the things to keep in mind is that with each one of the operations, there's an expected amount of weight to come off, right? So one of the things is to think about, well, what is that number that I'm likely to achieve? So with a with a sleeve, it's about 60% of the extra weight you're carrying. With a bypass, it's about 70% of the extra weight. With a DS, it's about 80% of the weight. And so one of the things that we'll talk about preoperatively is this is the amount that we would kind of expect with this operation, right? So if it's 100 pounds, some people will lose 108, some people will lose 92. That would all be within a norm, but this is kind of what we would expect. So the amount of weight that you'll lose after a sleeve or a bypass, for a sleeve, it's about 3 to 5 pounds a week in the first 3 months after surgery is normal. And so if you're coming down, it's stair step in that first 3 months. And you have to take the average. So if I've had a sleeve and I'm 4 weeks out from surgery, should have lost between 3 and 5 pounds a week on average, right? So 12 to 20 pounds within that period of time would be normal. That's kind of just a normal trajectory for weight loss. And so we really look at the first 3 months. Am I on track? Am I not on track in terms of my weight loss? And then the amount of weight that someone loses at the 3-month mark generally will double by the time they're a year out. So if they lose 50 pounds the first 3 months, I would expect over the next 9 months them to lose around another 50 pounds. It's just kind of normal. So that next 9 months, right, the weight loss is clearly slowing, right? So if I lost 50 in 3, now I'm going to lose 50 over 9, it's going to be slower. And it's down, stable, 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 drop, stable, 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 drop. And so you'll be going along, and then I just lose 5. During those plateau periods of time is when I really want patients focusing on these PFS principles. Am I doing all of this? If the answer is yes, you're going to keep losing. It's going to keep coming down. It'll still happen. If I'm not doing them, or I'm really kind of not making progress in these areas, the plateau just tends to be longer, right? It'll still come down, but the plateau tends to be longer. And so, that's the way that we approach it in the clinic. I will talk with every time I see a patient back, if they're, 6 weeks out, I'm going to look at, are they on track in terms of their weight loss, where I would expect them to be. I would tell you, so again, remember, it's a bell curve when we do these. So if a sleeve patient is off the curve, right, they haven't lost quite as much, sometimes they need a medication to help them, right? Because a sleeve patient doesn't get the same metabolic boost that a bypass patient gets, right? So that may be a patient I put on a GLP-1, a Wegovy, semaglutide, at 2 months post-op, because I want to get them back on their curve. It's not that they're doing something wrong. Their body's response to the sleep just isn't as powerful as some other people's response. But I can help them with that. Again, that's why the follow-up becomes so important, is there's some things we can do to continue to help with it. In terms of falling off track, so if I'm off track, I'm 2-3 years out, my weight's starting to recur. One of the things that I think you definitely need to do is get back involved in the program. I think that helps. Go back in and see, is it my hunger out of control? What is it what habits do I have that I need to be working on? And then we start tackling those one by one. So for me, the first thing always, when I see a patient, if they're seeing some weight recurrence, number one thing, thanks for coming back. This is where you should be. I'm super happy, you made it back to us. Number 2, what liquid calories are we getting in? Easiest thing to get rid of. Like, we're going to get rid of liquid calories. We're going to do that all week. We're going to still have plenty to drink, but we're just not going to drink liquid calories. And then I'll usually start on the eating side first, because that's where you see the biggest difference in terms of weight loss. Weight loss is about calorie restriction, right? So I can reduce calories, I can reduce snacks, I can reduce liquid calories, and then I can really work on recognizing I'm hungry, I'm not hungry. So those are kind of the first things that I tend to work on with patients. If they're coming back with some weight recurrence. And then I use medications as well in my post-op patients, because for me, the number one thing always is hunger. Are we getting hunger control? If we're not getting hunger control, I don't care how disciplined you are. If you're hungry, you will seek out food. We can fix that. We can work on those hunger and knock down those hunger cues. So it is not age related. Right now, I don't know if you can hear, but you're muted. I can't hear you.
I muted myself because I was typing some responses to some of the questions that you had. So Marguerite says, Marguerite, I'm 74 years old and 1 year post-op. Why is it slow for older people? I've lost 65 with the sleep.
So that may be normal. Again, it depends on where you started as well. And a sleeve is not as powerful metabolically as a bypass. So again, it's difficult to compare sleeve patients to bypass patients, right? So if you're talking to a bypass patient, they say, oh, well, I've lost 110 pounds. Again, that may be normal for them with their procedure, but it also depends on where you started. So part of the information that we have to be able to look at is, where did you start? So if your BMI was 36 before you started, you're not going to lose as fast or as much as someone whose BMI is 56, right? All of those things play a role in there as well. In general, I will say, when we look at that bell curve of weight loss after each of these operations, patients over age 65 tend not to lose quite as much as those under age 65. It's not a huge dramatic difference, but it is a difference. Part of that is already from a metabolic standpoint, your body has started to slow. All of ours do as we age. The metabolic rate starts to slow. Probably the most important thing for people over age 60 for sure, age 50 probably, the data is going to tell us loss of muscle mass. And so getting my older patients to exercise, build muscle mass makes a huge difference in your weight loss.
That was a great answer. That was a great answer. So, question, what was the answer to the seeds? How many
Sunflower,
calories?
650 calories, 1 cup of sunflower seed. Crazy, crazy. Yeah.
We had lots of close guesses.
Did you? Oh,
Um,
good. I was shocked. I didn't know that. I was thinking, oh, that's not such a bad thing. Wow.
Somebody said, Jessica says that's half my calories for the day. It
Yeah,
probably is.
exactly right. Exactly right. Exactly right.
Um, is there a short answer to this question? How about severe food cravings? I feel like you kind of answered that a little bit.
Yeah. So cravings we know come from multiple different places. And it also depends on what the craving is. It was a sweet craving or is it a salty, crunchy sort of craving? Sweet cravings in general will start to come back if I reintroduce sugar on a regular basis. The further we get away from sugar, the less we want it. And so one of the things we'll do for patients that are really having a lot of sweet cravings is try to start substituting non-sugared things in so they still feel like they're getting a little bit of the sweet, not with the calories, not with the sugar that's driving it. The second thing I'll do is there's a great medicine called Contrave. It's a combination medication that really knocks down cravings. I love it for patients that are having significant cravings. And you don't have to stay on it long term. A lot of times it's let's get you on the medicine, let's get the cravings under control, and then let's look more at what the root cause of the craving is, right? And a lot of times those cravings are ultimately going to be comfort things, right? I always I would reach for this, right? And now I kind of want it again. And cleaning that environment is probably the biggest thing. It's never a patient never goes from I have a great food environment to a horrible food environment overnight. It's little things that start coming back, into the pantry or little things that start coming back into the kitchen. And now I see it, now I want it, right? And a lot of times out of sight is out of mind. So let's get it out of the house and we can start working on, like I said before, willpower is a muscle. You have to work out the muscle. And the more that you work that out, the easier it becomes, the stronger you become and saying, no, I don't think.
Really? What temperature is considered cool in the bedroom?
Less than 70 degrees
Okay.
is ideal, ideal sleep temp. But, and you'll know this just by like during winter, right? You want to be bundled up underneath the covers. It feels good. And oh man, I slept so good. It was nice and cool out. It's really your core temperature that makes the biggest difference. And so the lower you can get that core temperature, the easier it is to get into the deep restful sleep. Again, people can sleep at warmer temperatures. It's just harder to get into the deeper sleep, that restful sleep. The REM sleep is where our body heals itself. And when I don't get into that restful sleep, I may sleep for 8 hours. I just don't feel like I slept well.
It's interesting how 1 degree can make a difference too. It's funny. Okay, there's 2 more questions I'm going to take. We're getting here towards the end of our Q&A box. I can't believe it. We had so many. Donna says, "What's a good thing to drink? I have caffeine or carb drinks or so. I can't have caffeine or carb drinks or soda at all. I've done lemon or lime, no sugars, or fake. I've tried teas, but can't do those as well. Is coconut water fine? I know it has a lot of sugar, but it helps me drink more fluids."
So I guess some of that might be how far you're out from surgery as well. If you're really early on after surgery, a lot of things don't taste good to you during that early phase. As we burn fat, our body produces something called ketones, and those ketones are what cause taste changes for patients in that early phase, where things that are sweet taste super, super sweet. All the flavors are enhanced. That's because of those ketones. There's something called alkaline water. You can find that at your local supermarket. The alkaline water has a different pH than normal water. And so, especially in the early phase, most patients tolerate that a whole lot better than they do just plain water. For me, when it comes to liquids, my only requirement is that I want them low to no calorie. Is the only requirement. So then it's just trying different things and seeing what you like and what you want. The flavoring, water flavoring, certainly. I don't like plain water. I just don't like it. And so if a patient says, I don't want water, I'm like, okay, great. Don't drink water. I don't care. Drink Gatorade Zero. Drink whatever zero drink you want to drink, certainly fine. And a lot of times it's just trying different ones and see how it tastes. Just kind of touch on caffeine kind of quickly because I know it's different with different programs. For me, though, I tell patients I don't want you on caffeine until you're up to your 64 ounces. And the only reason is caffeine's a diuretic. And when you take caffeine, you have to drink more in order to make up for that. Once you're up to your 64 ounces, caffeine has actually been shown to be an appetite depressant, right? So people that are on caffeine are less hungry than those who aren't. So I don't mind you being on caffeine, but I want to wait until someone's up to their 64 ounces. That's my philosophy. Again, not everybody can do that.
Okay. How is the excess weight determined? If a sleeve patient is expected to lose 60% of excess weight, how does the patient determine what the excess weight number is?
That's a great question. So the way you do that is you look at what your weight was before surgery, what your ideal weight is, right? And that ideal weight you can get on Google and put in ideal weight calculator, and it'll ask your height, and then it'll tell you what your ideal weight is. You take what your weight was minus your ideal weight, that's your excess weight. So your weight, actual weight, minus your ideal weight equals your excess weight. And whatever that excess weight is, that's what you take times 0.6, 0.7, 0.8. And we'll tell you the kind of expected weight loss with those. The other easy way to do it, this is a bariatric surgery thing. We always talk about excess weight. Medical weight loss talks about percent weight loss or total body weight loss. So for sleeve patients, that should be about 30% of your total weight. Bypass usually 35% total weight, and duodenal switch 40% of total weight. They're kind of roughly the same.
That's helpful. Yeah. Well, I just got to say thank you for your time, your energy. Everybody here is saying all kinds of really kind things. We appreciate each of you. And really, I feel like the time that these people are spending on themselves and learning, I love it because the most important thing is in your journey is you and being focused on this. So appreciate each and every one of you that attended. And Dr. Stegemann, thank you so much for your time and for this amazing, great information, these prescriptions for success. And I'll connect with you and we will talk about getting anybody that's listening to the live event a copy of your PowerPoint. And for anybody who's listening later that wants a copy, you can reach out to ProCare's customer service number or to me by email. So, and again, my last name, Hoehn, HOEHNB @ProCareNow.com is my email. So I also want to say as a closing note, we do have a lot of patients that watch these events and require that they're using that attendance for pre-op for pre-surgical qualifications for their insurance. I send attendance to about 50 facilities. So I will get that sent over to your facilities. Usually I do that 1 week post to kind of get in some of the replays as well. So just to let you know, yep, James says me. So do you have any closing thoughts, Dr. Stegemann, that you'd like to say?
would just reiterate what you said. If you are here tonight and you're so far along the way of maintaining your weight loss or getting ready for surgery, and I just say congratulations to you. It's always a work in progress, right? It's always a work in progress, and being here is a huge step on. And I congratulate you for coming. I appreciate the opportunity, Brenda, for the invitation to come in and speak as well. Very enjoyable. Thank you. I appreciate it.
Yes, thank you too. And each of you have a great evening and join us here for our next one. And Dr. Stegemann, I hope to see you in person again sometime soon. I know we met at the FASMBS conference and hopefully see you there again next year.
Sounds good. Thank you, everybody. Have a
Thank
wonderful
you.
evening. Bye.
Bye, everybody.